Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning. In this episode, I'm really excited to be speaking to Professor Willie Hamilton, who, having worked in general practice for many years, now leads the field in terms of UK cancer diagnostics. He's Professor of Primary Care Diagnostics at the University of Exeter. He was clinical lead on the NICE guidance on referral for suspected cancer, and Willie and his team have also produced risk assessment tools for all major adult cancers. These provide the GP and patient with an accurate estimate of the risk of cancer when a patient reports symptoms to their GP. Hello, Willie. Thanks for joining me.
Hi, Rhiannon. Thanks for inviting me to join you.
So I'd like to start by asking you a bit about yourself and what inspired you to work in the area of primary care diagnostics and how things have changed over the time that you've been working in this field.
Yeah, I mean, you always start with a tricky question. I don't absolutely know why I ended up in diagnostics. I mean, there's so many other fields within general practice that are relevant. I suspect it's because of the sort of intellectual puzzle of diagnostics. I love crosswords and quizzes and things like this, getting nerdish. You see, it's a crucial piece in the jigsaw puzzle.
So how have things changed in this field in the decades that you've been involved?
I'll start generally and then I'll move on to the cancer field. I mean, I think what has changed, I started my research career around the turn of the century. That makes me sound really old, doesn't it? At least I didn't say the turn of the millennium. I think what has happened is there's an increasing recognition that diagnostics isn't just as easy as it was purported to be. And that the simple model of patient came in, described symptoms, you put a hand on their belly, you maybe ran some tests, and boom, the diagnosis emerged. We've recognized it's too simplistic across diagnosis as a whole, but we've also recognized that you then need to do research on it, and so picking off the epidemiology of diagnostics. We recognized from the mid-90s that we were so far behind in cancer outcomes in this country. What was then difficult was to work out why. Was it diagnostic? Was it therapeutic? Was it that the people of Britain were simply ill and they were dying irrespective of either of those two? And very simply, we sort of apportioned the difficulties we were in cancer outcomes to about half of them being diagnostic. And probably that was right. This was Mike Richards flying a kite in the early part of this century, saying that. I mean, we didn't have great evidence, but actually it turned out to be right. Mm-hmm. Diagnostics in cancer has changed dramatically. The first and actually probably most important bit of that was it switched from being a secondary care subject to being a primary care subject. And we sort of increasingly realized that GPs were recognizing the patients who were at risk of harboring a cancer, not actually diagnosing the cancer, but diagnosing the patient as being at high risk, and then involving secondary care in doing the definitive diagnostic test. I mean, having said that, you can immediately blur it by saying the GP could actually do some tests. We could do the chest X-ray, we could do other imaging and things. We could sometimes do bloods or whatever. And there were some cancers that actually remained pretty much in the general practice arena. So identification of melanoma, for instance, it is visual. Yes, dermatoscopy helps, and yes, dermatologists are better than we are. But it was very much the shift from this being a secondary care subject to being a primary care subject, and that shift brought other changes in its wake. Of the changes that we made such a thing of in the NICE guidance, that actually you can only then select patients for referral if you know what's going on in the GP's consulting room. You can't use secondary care evidence to help you make the decision about what's a primary care decision. You had to do primary care evidence. And so that kick-started my career in seeking the primary care evidence, of which it was essentially next to none. I was really lucky landing in virgin territory. And it was lucky. What happened was I became completely deaf. And actually, I had to stop my clinical practice for a while, just at the time when my research career was beginning. And then this avenue opened in front of me. The change has been switch from secondary care to primary care evidence building up. And then the next phase was researching the primary care tests. So there is still, despite all we're doing, a sort of naivety among the public and to an extent among clinicians, but less so, that tests are black and white.
Mm-hmm.
That if I do a test for someone, chest x-ray, for example, it will give me the answer. Whereas in fact, there's an increasing recognition that, yes, it may give me the answer, but yes, it can be wrong at times. We all now know that somewhere between 20 and 30% of chest x-rays in patients with a lung cancer are initially negative. And the same goes for pretty well all the tests. I mean, somewhere between 10 and 15% of FITs for colorectal cancer are negative, CA125s, etc., etc., etc. It was ever that, but we just didn't recognise it.
Yeah.
So there's been quite a lot. Sorry, that's turned into a lecture, Rhiannon. But there's been so many sort of shifts of emphasis in the last 20 years.
So can I pick up then on you talking about the move towards bringing cancer diagnostics into primary care or indeed into the community? And what are the benefits and the drawbacks here? What do GPs need to be aware of when we're thinking about that shift?
Let's start with the nice bit, the benefits. And of course, the benefits for the patient. Because we haven't even mentioned patient yet. All this works for the patient. Of course, it helps the GP not being sued, but that's simply a pleasant spin-off. If we get selection of patients for definitive testing for cancer right earlier, then we buy them some time. And it's not lead time bias, which a few people have accused us of in the symptomatic arena. I just don't buy lead time bias as being important. There was a wonderful paper in the Lancet, I can say so because I had nothing to do with it, but it really was wonderful, which used the COVID data to try and estimate the harms caused by delay in diagnosis. In fact, this was delay in treatment, but delay in treatment is not that much different from delay in diagnosis. It's just delay. And the broad figure, which I think your listeners can go away with, was that for every week's delay in diagnosis or treatment, the survival is 1% worse. Now, that's a very broad figure. In some cancers, it's higher. Some cancers, it's lower. Some ages, it's higher. Some ages, it's lower. But a 1% figure, I think, is a pretty good overall figure. So 4 weeks delay. I mean, the average time for the patient coming in with their first symptom of lung cancer to actually have their diagnosis is actually about 2 months.
Yeah.
So that's 8%.
Yeah.
That matters. One patient in 12 will suffer from as a result of that. That's 100 divided by 8. The key bit for GPs was actually we're doing a job that matters. Patients always believe this. Most GPs have believed this. We've now actually got a figure to make that tangible. I'm going to go back to what I said earlier. Our job is not to diagnose cancer, except in the rare things when a woman's breast lump is clearly malignant. We've all felt those. And it's ghastly for the woman, it's ghastly for us. And the melanoma that we're pretty sure we've seen. And the patient has obviously lost a lot of weight. It looks ghastly. It's to identify the patient who needs definitive testing.
Yeah, that's an interesting way of thinking about it that I hadn't thought about it that way before. So that are the kind of benefits to the patient of bringing cancer diagnostics closer to home, if you like. What are the drawbacks?
Well, yeah, let's go even further and call them harms. They are both physical, mental, and financial. So if I go through them in order, yeah, let's take the NICE guidance, which, as you said in the introduction, I had my hands all over. That was the clinical lead. We, in our wisdom, said that a patient with a 3% or higher risk of cancer warrants urgent investigation, whether that is in a specialist unit or whether it is within general practice. It doesn't really matter. So 3%. Now, the reciprocal of 3% is 33. That means for every patient I investigate at a 3% risk, 32 of them will not have cancer. And that costs money, which the taxpayer increasingly reluctantly provides. And the NHS is not exactly awash with cash at present. It fills up outpatient clinics, it fills up imaging services. So there's the whole, if you lower that 3% further, of course, the figures multiply up. Actually, ultimately, they don't multiply up as much. When you drop to 2%, it actually makes very little change. You drop to 1%, it makes a huge change. Yet there just don't seem to be any symptoms between the 2 and 3%. Well, the good Lord's just decided that they don't exist. So there's the financial. There's also the emotional, if I can use that term. Me telling you cancer is a possibility is not a positive life affirming event. It scares you stupid. While you are generally relieved whenever the definitive testing comes back negative, it's hard to know whether your relief is absolute. There are costs, and I use the term cost very broadly, in investigating for cancer.
Yeah. I mean, presumably a lot of patients, though, it wouldn't be a surprise to them if you're mentioning sending them on a cancer pathway, and perhaps it's something that they might even want.
Oh, they do. They do want. When we did a big study, oh gosh, it's now probably almost 15 years old, which was very influential. Where we asked patients, we gave them a scenario of a possible cancer. I said, "This is you. The risk of cancer is X, and X was either 1, 2, 5, or 10%. And we sort of dialed up the scenario to make you iller and iller to get you up to 10%. And we said, here's the testing for this particular cancer. Here's the outcomes if you have this cancer. Whatever effectively, we tried to draw as realistic a scenario as possible. And the patients were biting their hands off to be tested. So much so that even at 1%, there were well into the high 80% of people saying, test me now, test me now, test me now. And we chose pancreas and lung, which at that time were pretty ghastly cancers. Pancreas remains pretty awful. Lung were making serious therapeutic breakthroughs. These were cancers that, if I'm honest, at that time, you were pretty well as a death sentence. Yet they still wanted to be tested. Oddly, the only one we thought there would be an increased willingness to be tested as the risk of cancer rose. We thought people would think statistically. They didn't. They heard the word cancer and said, test me. The only but we got this sort of upward moving curve was colorectal. And I'm quite sure that was just, I was a bit too graphic in my description of colonoscopy. And in particular, the prep for colonoscopy. And I think that threw people off. So patients do want testing. Your point also was, are patients thinking of the possibility of cancer when they come into the consulting room? That is very much symptom dependent. If you take a breast lump, there is not a woman in the land who presents a breast lump to general practice and who hasn't thought of the possibility of cancer. So in a way, for the GP, that consultation is decision-wise dead easy. Emotionally, it's very charged because she's terrified. But in practice, the consultation will be, how will we deal with this and make sure it's cancer or not cancer? So, I mean, in a way, it runs to a smooth pattern, even if it's emotionally terribly important. Other symptoms are not by any means as clear. That even something as simple as rectal bleeding, the cardinal symptom of colorectal cancer. But obviously, it's still only 3% roughly. So the hemorrhoids, the other things come in. There isn't the same joint understanding at the beginning of the consultation that we are dealing with a cancer possibility first, and then anything else is a lesser importance. So GPs are generally euphemistic when it comes to the lower chances. They say That mentally, their inner dialogue is, look, this is a 3 to 5% chance. I don't want to scare this individual stupid. Uh, so they either use a euphemism, let's check there's nothing serious, or, well, I don't think it is cancer, but my guidelines tell me I've got to do this. Blame the guidelines, blame Willie. It's not me being nasty, bringing up the possibility of cancer. It's all Willie's fault. That sort of thing, just deflecting the stuff. It's interesting though that euphemisms work. Certainly don't work if you get a letter from the hospital saying urgent suspected cancer. Please turn up.
Yeah. Yeah, and interestingly, I talked to one of my previous guests on the podcast, Peter Johnson from NHS England, looking at the statistics of people who are referred on a suspected cancer pathway, that 94% of them turn out not to have cancer. I was quite surprised by that, actually, in a pleasant way, because I do think for the general public, the thought that they've been referred on a cancer pathway, they're thinking, well, the likelihood is that I have cancer. And of course, the overwhelming likelihood is that they don't.
Yeah. It is a tricky one. PJ's always right. And I completely agree with PJ in this one. That is 94% will be negative. Now I said a 3% risk, a 3% risk. Anybody above 3%, also. So if you have some symptoms that carry risks above 3%, the overall risk is 6%. But against that, we've got the patients in mind, the last little bit where I said, look, patient want to be tested anyway. So I think if you said to the patient, please come to the urgent suspected cancer clinic, the likelihood is you won't have cancer, but we still want you to come to be sure. I think patients would take that aboard. It's a pre-reassurance, but I think until you've had the definitive test, you don't get true reassurance.
Yeah. I want to come back to what you were talking about just then in a minute about the sort of constellations of symptoms and, the more vague symptoms. But for now, I'm just going to ask you a bit about the risk assessment tools. I mentioned them in my introduction that you and your team developed for use in primary care. So could you tell us a bit about what they are, how they're designed to be used in primary care?
Absolutely sure. We have worked out the percentage risk of cancer for individual symptoms for a cancer for a patient aged over 40. I'm not going to ask you to give your age, but can I briefly make you over 40? If you, I'm going to.
You can see me on the video. This is the.
I'll wave my magic wand and make you back to be a youngster again. So if you come in to me with a lump in your breast, I can say it is X%. And that will help me to decide, A, whether investigation is possible. That's not a good example, but with a breast lump in you now being over 40, the risk is clearly high enough and I'm going to refer anyway. But I can make referral decisions and the NHS can make decisions and provision of testing. Too. So it works both ways, both in us selecting patients and in secondary care being prepared to take these patients. So we did all this for single symptoms, but then some cancers, indeed most cancers, are polysymptomatic. And I don't mean by polysymptomatic, there are lots of individual symptoms, each of which are risky, which is actually true, but actually that they have multiple symptoms simultaneously. And the classic of these is lung. Lung is almost never a single symptom cancer. The idea of the patient coming in saying, I cough up blood, otherwise look perfect, and then transpiring to have lung cancer, that is hogwash, and that's back in the Victorian times. Hemoptysis has almost disappeared. Even nowadays, if hemoptysis comes, it'll be associated with cough or shortness of breath or loss of weight or all four. So we moved on to looking at pairs of symptoms. So if I take hemoptysis plus loss of weight, the risk goes up. I'm guessing, but I'd have to look at a piece of paper in front of me, but it goes up from something like 2.4% to probably 7 or 8%. When you have got two symptoms reported to the GP, then the risk goes up higher. We then produced a colour-coded risk assessment tool, the colour coding reflecting the risk of cancer, with red obviously being about 5, orange being between, I think it's 2 and 5. This was in the pre-NICE era. And then yellow being risked below 2%. So these were all calculated and all published over the 18 main adult cancer sites over a period between 2000 and 2010, roughly. It's allowing a GP to work out for themselves what the risk of cancer was. But then the most interesting bit was the how do we get this to the GPs? We published in GP sensible journals, so the BJGP, the BMJ, a few others out there. But to be honest, no sensible GP reads primary research. They're too busy. They have too many other topics to do. I mean, I still read the BJGP from cover to cover, but that's unusual in that respect. So what we had to do was get it out. And the first thought was, with a lot of help from the NHS, was some calendars. Well, that's all very well, but the year changes. So every year your risk assessment tool goes out of date. And no one wanted sensibly to keep spewing these out year after year. So we moved on to mouse maps. I can't remember which body it was. The body's now defunct, and they're probably defunct because they made 60,000 mouse maps. With the lung and the colorectal risk assessment tools. It was great, but there were only 40,000 GPs at the time. So for a brief
period, the data, were they?
Wasn't quite the best use of numbers. And to the extent that at one point I had something like 10,000 of them delivered to my office in the university. You couldn't get into my office for mouse maps. I managed to distribute them large and wide. But even mouse maps are so 20th century. That we moved on to electronic tools, and I think that's the one that's of most relevance to today's listeners. And what these do is every night they interrogate the entire GP's computer, add up symptoms that are appearing in the record for the last year, in the GP's notes, calculate the risks of cancer for relevant cancers. So weight loss could be more than one. And then they update, in effect, the GP's notes every night so that if in the morning the patient comes in and the GP turns the computer on and Mrs. Bloggs comes in, a pop-up appears on Mrs. Bloggs' screen saying, we've calculated the risk of cancer here based on the fact that she's lost weight and has a hemoglobin of 8. We think her risk of esophagogastric cancer is X percent, her risk of lung is Y percent, etc., etc. And that pops up on the GP screen. There's some slight disadvantage because it pops up at the beginning. And Mrs. Bloggs might be coming in to talk about her HRT or something completely different. So there is a wee bit of an issue that pop-up fatigue is real, and GPs hate pop-ups by and large, but they know they're there for a good cause, but they hate them. And it doesn't necessarily link in that easily with the consultation. But it does, again, give you the chance to say, all right, we sorted your HRT. Are you happy with that discussion? I just want to ask you about your weight loss and the fact that we spotted anemia. Could this be da-da-da-da-da? And then you open it up. These have been available for some time. There's a sister type of risk assessment tool called QCancer, which wasn't developed by us. It was developed by a Nottingham and Oxford team. The beauty of the risk assessment tools is we're now doing the main, or almost finished the main trial. We've actually trialed risk assessment tools across 7 cancers in somewhat over 400 practices, with half of them having the tools for 2 years and half of them not having the tools for 2 years. And we will see if having a risk assessment tool causes a stage shift. Because ultimately, you want to diagnose cancer earlier, and if you diagnose cancer earlier, you might get it at a better stage. So we will have the results of that, unfortunately, not through to 26, risk assessment tools or RATs. They may work. I won't know.
So these are already integrated into some GPs' systems, and it is a case of it scouring the data that's already been inputted, that's coded in terms of the symptoms, and popping up to give a kind of warning, if you like. Is there a way that GPs would use it where Mrs. Bloggs turns up and says, I've lost weight or whatever other symptom, that it's like the GP could cross-check it and go, yeah, okay, they've got this, this, and this, therefore.
Yeah, there's two other functions, one of which we think is useful, one of which we've got question marks about. The first function is what you've described, that Mrs. Bloggs could come in, the GP can say, oh, that's interesting, you've lost weight. I just want to ask you a few other questions about your weight loss to see if I can home in on what's causing it. And you can open up the risk assessment tool, click on the additional symptoms, and then recalculate it. And it will not only recalculate the total risk of cancer, it will tell you what the individual cancer site risks are, because loss of weight's a tricky one. Really well, any cancer can cause it. It's not just in late stage disease, but even in early stage disease. So you need to know which cancer to home in on. So yes, you can use it as a live tool to help your decision making. The other one that I hesitate to tell you about because I'm not sure it's useful, but you can actually run an audit, shall we say, every month of your patients who have apparently got risks above an agreed percentage who have not been investigated. Now that is tricky, and it's tricky because what do you do with the data? Do you ring up Mrs. Bloggs and say, hey, you were in the surgery 5 weeks ago and now we think we missed a cancer? That's actually quite a tricky one because you probably didn't miss a cancer. You probably thought about it in practice, decided to treat Mrs. Bloggs or whatever is going on, and whatever. So the issue of cold calling someone whenever you have identified a previous risk of cancer is a tricky one. Although in fact you do capture some cancers that way. So it is quite a tricky one. But we're concentrating on the two live functions of risk assessment tools and allowing GPs to use the audit function if they wish, but with caveats.
So to return to that mechanism that we talked about there, where someone's presenting and saying, okay, forget about weight loss for now, say they're presenting with postmenopausal bleeding and one other symptom. There are two things that come to my mind. One is that is reliant on people disclosing symptoms that are like ancillary to their main concern, I suppose. And like you say, people might not have cancer in their mind. They may not have made a link between the fact that they have weight loss and postmenopausal bleeding or whatever. And also, how does this work when you're operating like on a baseline of somebody with a number of other comorbidities and a number of other health concerns or whatever? Does that muddy the waters somewhat, or?
You've made two separate points. Let's deal with them separately. The first one is it relies on the patient voicing a symptom, but it also relies on the GP coding the symptom and putting it down. You're absolutely correct that both those stages happen. To be fair, the risk assessment tools statistically were based on recorded symptoms. So to some extent, there is an increase in risk from you experience a symptom at home. So you having your headache at home. We've all had headaches and we've just taken paracetamol and we lived on. To you coming in to see me in my surgery saying, Willie, look, I've had these headaches for 3 weeks. Your risk for brain tumor has now gone up because something has changed in you that makes you think this headache is unusual. If I write it down, the risk comes up again. Now, the risk is the same, but it's not a high risk phenomenon. Because I think it's important enough that I've thought, hey, look, Rhiannon was in with her headaches, and it's important I've written it down. And in each of these, the patient gets the risk of a brain tumor is going up. So I actually don't mind too much the note-keeping aspect of it. The second aspect of it, you said, well, look, does it muddy the waters? I'd say the waters are already muddy. In that, if you've got a patient with a comorbidity, can that comorbidity, which can bring symptoms, mask the existence of a cancer? The symptoms of COPD overlap with the symptoms of cancer, and although I know that the chance of lung cancer in a COPD patient is higher, I could get lost in COPD treatment and not consider cancer. In fact, that's where the risk assessment tool actually helps, because very simplistically, 50% of the cancers that are not diagnosed quickly in general practice are because they have not thought of cancer as a possibility. The other 50% are delayed because there's something in the system that gets in the way. So you get over that first aspect of, hey, the COPD patient I was assuming was just an infective exacerbation of the COPD actually could get cancer. So it increases my willingness to do chest x-ray. And oddly, there's increasing evidence that having comorbidity actually makes the GP more likely, not less likely, to investigate for possible cancer. We all assumed for ages that the situation's so complicated that cancer gets forgotten. It seems the other way around. Now, whether that's a victory of NICE or a victory of all my risk assessment tools or all the media stuff going on about cancer, but actually patients with a comorbidity are now being diagnosed with a cancer at an earlier stage than patients without a comorbidity rather than a later stage. Very unusual, very unexpected, but actually quite good news. So risk assessment tools have very much got their part to play in the comorbid patient or multi-morbid patient.
So how well used are they at the moment? We talked about how they are integrated. Is this something that, well, what proportion of GPs are accessing them and sort of using them?
Oh, relatively few, because the current position is that the risk assessment tools have to be hosted on a platform which the GPs have to integrate, and we effectively paid for the platform through the trial. What I think will happen, let's say the ERICA trial that I've described is positive, and it shows that it works, or at least shows that it seems to work. I mean, there's always a problem on any trial that a positive effect is lost because you simply don't have the power to show it. So let's say it's a good result from ERIC trial, however you define good. I think we would probably find that Cancer Alliances and the Department of Health would support those coming into day-to-day practice, and they would sort out the hosting of them. Now we've got all their RSA approvals and everything else, so it's all legal on above board and everything else. It's now just a matter of something finding the dosh. And I'm pretty sure, given the importance of cancer, given that they're both the political and the NHS drive to try and improve cancer figures, that they would find money not down the back of the sofa, because it would be more than that. It would be the whole sofa itself, I think, to support this. I'm not trying to put pressure on PJ and his colleagues, but I think they'd find the pressure themselves.
You said that these were developed for the most common adult cancers. Would the same principle work in childhood cancer?
Rhiannon, this is where I'd love to say yes, and I'm going to have to say no. We've done them. The problem with childhood cancers, our childhood cancer is so jolly rare. That's good news, not bad news, of course. So forgive me. From a researcher viewpoint, it's terribly difficult. And I've talked to I don't know how many pediatricians, and we've tried our best, and we've done a sort of risk assessment tool equivalent for pediatric cancers. The problem is the risks are so small that in effect, if you use them to light up something in a computer, then you'd be referring so many kids, it'd be crazy.
Yeah.
What I think our position now is, we need GPs to use their wisdom, and wisdom means listening to the parents, hearing the parents worry and whatever, examining the kid and whatever, seeing the consultation pattern that's changed here, and using all these things that we're taught about. The GP's gut feeling is real. So it's the famous ability to recognize a sick kid. I'm sorry, that sounds terribly unscientific, but actually we're highly qualified individuals as GPs, and most of us are highly experienced. And obviously experience comes increasing over your career. So it is down to recognizing the sick kid.
I know. I'm pleased that you mentioned that, because that was actually going to be my next question, was around how the risk assessment tools, or any kind of clinical, decision support tool, how does it fit in with this idea of sixth sense and the GP's intuition.
I'll take it away from kids because in fact, I made it clear
This
about
applies
kids.
across the board.
If I bring it back to adults, what I don't want these to be knee-jerk things. What I want them to do is to open the conversation. And indeed, this ability to recalculate risks. If this pops up on the screen, remember you're now still over 40. I can't remember what you got, weight loss, I think it was. It pops up and I recalculate it. And I should be doing this with the patient. I'm not just doing it as a slave to the electronics. We actually set the trigger to go off at 2% in electronic risk assessment tools, which is below the NICE guidance, because we think that once the conversation has begun, the risk will be adjusted. Some of these initial 2%ers will go up, in which case you may well then want to investigate. Some will go down, in which case you're happy to safety net or reassure or whatever you're going to do. I'm an absolutely firm believer that these are aids or adjuncts to good clinical practice. They do not replace good clinical practice. In the very front of the NICE guidance, I had to write the sort of, I don't call it a disclaimer, but they get out a jail-free card. It says something like, there's 1/3 new cancer diagnoses in the UK every year. We do not have them all in the NICE guidance. We want you to use your wisdom to make referral decisions and to deny referral decisions when you believe it is correct. That isn't the wording I used, but in effect, that's what I wanted to convey. That actually the most important thing is you and the patient in there. The risk assessment tool is just helping you a bit, or the NICE guidance is helping you a bit.
So to take it in the complete opposite direction then, how do you think, sort of looking ahead, technology might kind of impact this? I'm thinking about AI particularly, and the data and how that all might pan out.
Yeah, okay. Well, let's grab AI immediately and say, where will it fit in? AI is brilliant at bringing in multiple variables and variables that change over time. Whereas the relatively simple statistics that most people have used up until now has been relatively simple. When you do AI on the databases that I've got, it actually only increases the predictive power a pretty small amount. And that's because the simple statistics are actually not bad. So they're improving your accuracy from, should we say, 87% to 90%. Where that is a problem is how do you explain that? How can I say to Rhiannon, you've come in with this symptom and that symptom? Well, the computer says no. Computer says you don't need to investigate it for cancer. Whereas, in fact, if we go back to a simple, I say, well, yeah, you've lost weight, but in fact, your blood count is holding up, and you're not coughing, and you're not doing this and that. Now, I think we can afford to wait, and so I can explain it much better to you in conventions. So, AI in terms of patient selection for investigation, I think will have a small effect. I'm not saying it'll have a zero effect, but I think it'll have a small effect. Where I think it may be very helpful is in the initial investigations. The obvious one is image recognition. So pretty instantly you can think of the melanomas, and there's lots of apps out there, and I don't know how well they've been done, that are telling you you can buy one yourself. You don't have to go and see your doctor, and you can look at your skin and this brown blob. It'll tell you whether it's a good brown blob or a bad brown blob on your skin. But what about chest X-rays? If the chest X-ray could be looked at by AI first, AI is brilliant at saying it's clear. And it's brilliant at identifying the tiny little areas which maybe the radiologist could miss. But AI could say the first 60%, we're pretty sure these are clear. Will you concentrate on the 40%? And suddenly the radiologist gets twice the amount of time to look at it. I think that's where it will come in. I'm not being Luddite or nihilist about it, but I think it's downstream. GP notes are so complex, and the GP consultation is so complex with the nuances of it. I'm not saying we get it right the whole time by any means, but we do actually a pretty damn good job. And cancer diagnostics has improved dramatically. That's where I think AI will come in. Is downstream.
So to wrap up then, Willie, what do you hope that our listeners will take away from this discussion?
Actually, one blow. We're actually getting it right. It's that the percentage of cancers now at stage 1 or stage 2 in the last decade has risen from 53 to knocking on 60%, and the graph is going the right way. So that is general practice. You don't get to that any other way unless you bring in a new screening program. We haven't. So we have done fantastic. And every 1% is 3,000 patients changed from being essentially palliative care to being curable. So well done to all our colleagues in general practice. However, the job's not done. I want to get from 60, and in fact, the government wants to get from 60 to 75. They're not going to get to 75 for 2028. I've carefully sorted my retirement date for 2027, so I can't be told off. But we have to keep going to do that. And we have to be brave enough to trust ourselves and investigate. We're at the stage where, with all this last 15, 20 years, we've been talking about investigating smarter. Essentially, investigating smarter is not enough. You actually do have to investigate more. Now, then, obviously, there's an overlap between the two. So I think we GPs have to recognize that the job's not done. There are patients we will be sending for cancer investigations that we wouldn't have sent for cancer investigation 20 years ago. And as long as the NHS can afford to do that, we have to do it. Or we're not going to continue to improve. And we're not going to catch up with France, Germany, and Sweden. Which we should be. We shouldn't have bad cancer figures. So it's, I suppose I have to say it's 2 cheers for general practice. I'm a tough marker, and maybe I'll give them 2.5. But there's more to be done.
Yeah. Great. Thank you so much, Willie. I think that's a good place to end. So really appreciate your time today. It's been a great discussion. And so for all of our listeners, don't forget that you can claim CPD credits for listening to this podcast. Just go to our website, mimslearning.co.uk, and complete the podcast module to claim your certificate. This episode was produced by Till Owen, and we'll be back next week. So I hope you'll join me then.